Welcome to the Love is the Cure Foundation podcast. Today's episode is a deeply personal one and also an important conversation about the challenges and hopes within pediatric brain tumor research. I'm so happy to speak with Dr. Pratiti Bandopadhayay, affectionately known around here as Dr. Mimi. She is an oncologist and a lead researcher at Dana-Farber Cancer Institute, also part of the family at Boston Children's Hospital and the Broad Institute. Dr. Mimi was with us toward the end of our son Inigo's journey when we were facing some of the most difficult tensions any family can imagine. She was kind and generous with her time, steady and clear-minded and compassionate, guiding us through those final choices with such grace and honesty. One morning, in the middle of that hard stretch, she came in to do her rounds. And Inigo, who loved everything about Australia, looked up at her and asked if she'd sing Waltzing Matilda with him. With his usual boldness, he just assumed she'd say yes, and she did. It was such a beautiful moment, the two of them sitting together in that hospital room singing. A moment of beautiful connection in the middle of so much uncertainty, and one we'll never forget. Today, we're honored to welcome Dr. Mimi to this conversation. We'll be talking not about funding specifics, but about the bigger picture, the ongoing challenges in pediatric brain tumor research, the critical importance of collaboration, and the powerful role that families and researchers play together in pushing this field forward. Through Inigo's story and through Dr. Mimi's perspective, we hope to shed light on why continued research and compassionate care are so vital and how understanding science and love remain at the heart of every breakthrough. Dr. Mimi, thank you so much for joining me today.
Alfonso and Lindy, thank you so much for having me. It is such a big honor, and we've been talking, but Inigo completely touched my heart. Like every patient I do, we carry every child with us, and the fact that this podcast is called Love is the Cure, it sums up Inigo just so beautifully. This beautiful young man who is just full of love and kind and compassionate and creative and the funniest sense of humor. And taught us so much that we talk about him all the time still. So it's very special to be here.
I love that. That makes me so happy. You made such a deep impact on him. He had a real love for Dr. Mimi, and I think that's so special. And especially since your background as an oncology researcher was especially important for everything that we went through. As we broaden out the conversation here, I think our biggest thing as parents, when we entered into this field, not by choice, but by force, was reaching a place that we did not understand about. And as a parent, you never think about the background of research. And so as we broaden that out, we entered into a field where we had to quickly come up to speed on understanding that there is some deep research going on behind the scenes that gets to a place for our children to be able to be treated in the way that they are. Now, the difficulties with that for us is that Inigo needed to be treated traditionally. And I will say in retrospective, I hate that. I dislike that so much. And my desire now is so different because I understand a little bit differently. But can you give us a broad perspective on what research is, cancer research, pediatric cancer research, and when I talk about traditional treatment versus non-traditional treatment, what am I talking about, and why is your role so important bringing that to light?
That's a great question. And this job for me is one of the most humbling experiences because I meet families like you. Nobody wants to be part of this club. No one wants to know what a brain tumor is, especially a pediatric brain tumor. And the reality is that we are nowhere where we need to be, right? We need to be. You talk about how I met Inigo and how much he touched my heart and how special he was. But I hate that we didn't have the answers for him.
Mm-hmm.
And that means that we can't stop trying to find the answers. What we need is to have a treatment for every single child that's not going to make them sick and keep them in hospital for months, but will give them a chance of living for the next 80 years of their life and going on to do what they're supposed to do because they're cured. And we can't stop until we get there, right? And to do that, we need to understand what makes these tumors grow. We need to understand what our treatments will do and how to stop the tumors from coming back. So the good news is I think we're going to get there. And when I look back to think about how much as a field we've learned in the last 10, 15 years, it's been tremendous. But we have a lot of work to do. So, I grew up in Australia. This is not an American accent. I'm an Australian American now. I grew up in Australia, which is why Inigo knew the waltzing Matilda, this Australian folk song. I never thought I was going to be an oncologist, and I definitely never thought I was going to be a researcher. I was training to be a pediatrician in Australia. And in my training for pediatrics, I went to the oncology floor in Melbourne and met a little 2-year-old boy who had a similar course to Inigo. And just like Inigo had in me, this little boy, I remember seeing this and thinking, why do the treatments not work? And that sent me on this journey into this profession and to Boston ultimately, and into the lab, because the way we are going to change the stories for children like Inigo and all the children being treated now and the children to come is to really understand what makes a tumor grow, right? And then how to treat it. When I graduated from medical school, we used to treat a lot of these tumors like we learned from adult cancers. And the chemotherapy backbones actually originate from drugs that were used, decades and decades ago that target cells that are dividing fast. So that's what chemotherapy does. And that and radiation and surgery has managed to give, take tumors that were not curable and get to being able to cure many children, but they have side effects and we don't cure it enough. About a decade or 15 years ago, with the new sequencing, we've learned that not all tumors are the same and there are different subtypes, and we need to think about treatments differently. And now we're learning about new drugs that can target them. So, very long-winded answer to say research is completely important, and there are many people all around the world working as a team, which is what I love, right? This is not about which center is going to find a drug the quickest or which doctor is going to do. This is about researchers working all over the world together as one to find the answers for our kids, because we have to find better answers for our children.
Yeah. I do have a couple subsets of questions, and the reason why is because this is going to help me stay on focus, because of course this being so personal. So I'll just go through some of these. So for listeners who may not be familiar, what makes pediatric brain tumors particularly complex to study and treat?
Yeah, that's a very good question. So, brain tumors are arising in the brain. They're arising in the organ that make us who we are, right? And the brain controls every single part of us, right? It controls our personality, it controls what we remember in the day-to-day, it controls our movement, our breathing, absolutely essential. And the brain tumors can arise anywhere in the brain and anywhere in the spine. And that means that it can be difficult to always take out the tumor, right? So a lot of the times the surgeons will take out as much as they can, but we don't want to hurt our children. So we're restricted. If the tumor's affecting delicate parts of the brain, we can't resect it all. So that's one part. Another part is that chemotherapy drugs, or any drug, right? Not all of the drugs get into the brain as well as other tissues. And the reason for that is our brains have evolved to protect us from infection, right? We don't want to get meningitis. And so the brain has a barrier, literally called the blood-brain barrier, which tries to stop things that can hurt us from getting into the brain. But it can also stop things that we need to get into the brain getting in, like drugs. And so that makes what we can use to treat the brain tumors, the choice is a little bit less. And when we're developing new drugs, we need to be able to develop drugs that can get into the brain. The other thing is that brain tumors, when they occur in children, are by definition occurring in a child who is growing and developing. And I often look at photos of my little nephews and nieces, right? You look at a baby who's born, and then by 6 months later, they're sitting up. By 12 months, they're walking and starting to talk. The development is exponential. And compare that to us, right? I am lucky if I learn anything new in like a year, right? So the child is developing exponentially, and we want to not hurt that. So we need to have treatments. And I know that in your journey, you've experienced how treatments can really impact a child's normal development and ability to interact. So we try very hard for that not to be the case, and that can restrict some of the treatments that we need. The other thing is, and this is fortunately changing, and this is why I do see a lot of hope, is, for a long time, and it's still a challenge that we have, but we openly talk about and try to address it. A lot of the research in the past and drug development in the past has been for adults. But children are not just little adults. Children are children, right? And the tumors that occur in children are actually completely different to those that occur in adults. They have different mutations that make them grow. And so we're now starting to understand those mutations and in the lab at least find ways to target it. One of the big challenges that we have is it's a double-edged sword. On one hand, if you compare the number of children that get a brain tumor to the number of adults that get, for example, breast cancer or prostate cancer, the number of children with brain cancers is very small, right? We're talking thousands, like 5,000 to 10,000 in the US per year versus hundreds of thousands of adults. That's a good thing. We don't want more kids getting brain tumors. But the difficult part of that is that if you are a drug company who is publicly listed, who by law has to make decisions that will return profits to their investors, you're unlikely to make money by developing drugs specifically for pediatric brain tumors. And so in addition to all those other challenges that we talked about where the tumors grow and getting drugs into the brain, getting access to drugs for children with brain tumors is also challenging and something that we as a community keep needing to think about.
And that's not even speaking to the idea of insurance coverage. And if you're in a particular place where that, where some of those things are not covered. So when we're talking about traditional versus some of the research elements that you all are working on. So traditionally speaking, for an Inigo story, and I would guess with most children like him, he went through a course of radiation and a course of chemotherapy. Now, he ended up towards the end of his life going through a course of immunotherapy drugs that were part of these research elements. And I wish as a parent, and I alluded to this earlier, that immunotherapies, those secondary treatments, could be primary. Because of the toxicity of chemotherapy, because of the adverse effects that come through radiation. I dream now of what could have been. Now, in Inigo's case, and I want to publicly just state this in disclosure, as what was made known to us is we didn't have a chance to take those chances because Inigo's tumor was so advanced by the time it was discovered that there was no time. There was no time to try anything else but resection and then directly into those primaries. Are there moves being made? And I'm sure pediatrics versus adults has a lot to do with this, but are there moves to try to make those primary in pediatrics?
Yeah, I think that is a very important question. And the answer is yes, right? That's ideally what none of us are happy with the fact that our best treatments right now is radiation and chemotherapy. So I also dream of a day where we can get more effective treatments upfront with less toxicity, and they're effective. The challenge that we have, and I do think we'll get there, right? The challenge that we have is when you have treatments like we currently do with the radiation and chemotherapy that we know have side effects, but we know are able to cure a number of children, right? Versus when we're evaluating experimental medications where we don't know if they even have any activity. It's hard not to use a treatment regime for which we have activity compared to something that's experimental. But I think what's going to happen is the first thing for any new drug, right, is that there needs to be early phase clinical trials where we literally work out what is the best dose that we should use, what are the side effects, and does it have any activity, right? But once we know that, then the absolute goal is to bring those treatments up front, and what we need to work out is how to bring it up with the treatments that we have now, and then assuming that that works and improves, and eventually how do we get rid of some of the other treatments. But all of that takes a lot of time, and it is incredibly frustrating being a parent and being a clinician as a researcher, not being able to know those answers straight away. But everyone agrees with you. That is where we need to go, is upfront with more effective treatments. And then, for tumors, as you just described, that are higher risk, where we know that even with the radiation and chemotherapy that we're not curing all children, can we bring some of these experimental treatments upfront to try and even stop that relapse? So, yeah, I and all of my colleagues, we 100% agree with you. That's where we need to get, is these treatments that we know are going to be more effective once we know that they're going to be effective into the upfront setting.
I have these feelings now because I've lost my child. And so of course I can think like this now, where if I knew the outcome of certain things, then I would have said, hey, let's try the long chance, straight out. But yeah, you're absolutely, you're speaking to someone that I think understands what you're trying to communicate, is that let's do the things that are efficacious first.
Right, that we know have the best chance. But then the other thing that we're also working on, and I think you'll sort of, if we're going to treat a child up front, are there things that can help us predict whether the treatments are likely to work or less likely to work? And we're definitely learning that every day. The sequencing and the subtyping that are done for a lot of the tumors have starting to help us understand, or starting to sort of when a child comes to clinic, if their sequencing has a mutation in gene X, then we might be a little bit more worried, versus if they have other genes that sort of a little bit more. So we're starting to use that to help guide the intensity of treatment and introduction of new treatments. And then the other question is, are there ways other than MRIs, which is what we use right now to track how well treatments are working, are there other ways that we can track the response, or whether can we pick up whether a tumor is going to come back a little bit earlier, and if we do something a little bit earlier, will that change? And you might have heard about things like blood biopsies that people are working on in the brain tumor space. It's often from lumbar punctures, but there's some of the things. And then ultimately, one day, the other dream is, can we predict which child is going to get a brain tumor before they even get that, and try to stop it?
Yeah, as a family, I think that's one of the things that we think about the most is, was this genetic? Was what environmental factors were involved? What, there's so many things that you think about, because you're always thinking about the we've lost Inigo, but there are so many more children that will come down with a medulloblastoma. And that's the other thing that I always try to communicate with people, is that medulloblastoma, and correct me if I'm wrong, is the most common brain tumor that in pediatric form. Is that correct?
It's one of the most common. There's, but yeah, there's gliomas, but yes, gliomas. It's one of the most common. Absolutely, one of the most common. And so every parent asks me, did I do something? Was there something I could have done? And I'll tell you, I'll tell Lindy, and I'll tell every parent that's listening, there's nothing that you could have done to stop this. Okay? And we have looked, right, are there things that happened in pregnancy? Are there foods or environmental exposures or toxins? And we have not found anything that, reliably puts up the risk of a brain tumor. We are learning more every day. Right now, in our sequencing, we're probably picking up about 10 to 15% of children. We can pick up another mutation called a germline mutation that might increase the risk of another cancer. So that's something we're looking for. But most of the time, we don't know what causes a pediatric brain tumor. We think that at some stage and this is different to an adult cancer. So an adult tumor, when you sequence it, right? So if I was to get a skin cancer right now, if you were to cut it out and sequence it, you would find lots and lots and lots of mutations. And those mutations would have a signature of being exposed to sunlight. So adults tend to get tumors that have lots and lots of mutations, and often because of environmental exposures, right? Cigarette smoking, sunlight, dyes, other carcinogens. But in children, they have very few mutations compared to the adults. Some tumors even have just one mutation. Medulloblastomas have a few more. But what we think happens is at some stage in development, when the brain is developing, and of course the brain keeps developing after you're born. It starts developing when you're in mum's womb and then keeps. But at some stage in development, all of our cells all across our body get mutations, right? But at a specific time in development, if a cell gets a mutation that turns on a pathway that should not be on, that then causes a tumor to grow. And so we're trying to work out what causes that, and also can we predict it earlier? Is there a way? But I'm going to keep telling Lindy, you could not have done anything to stop this.
Yeah, no, thank you. It's something that we think about, because we do think about the fact that those cells were in there and they were immature, and then something triggered them to turn on and to do what they did. And oh my goodness, that is the thing as a parent that you constantly think about. And especially as parents that we feel we were very healthy. We spent a lot of time in the outdoors, exercising, enjoying being outside. We're good eaters. We for very much of Inigo's life, he was vegetarian. And so we as a parent, you think you did all these things to be very careful in raising your child, and yet those cells were in there and something triggered that. And that's that. Oh man, I wish I could become a researcher, but then the realization, you are a researcher and you do this all the time. I'm just amazed at the continued desire to do what you do. Because for me, it comes from a parent standpoint. From you, for you to see what you do in that hospital space and desire to continue to find the answers, I think is something that the general population needs to realize, the heart that is involved in the work that you and your teams do to continue doing the research necessary to find answers to really hard and complex questions. And I don't know if we quite understand that as a general population. Only if you're in this tiny club of us who have had children that develop this. What can we do to get the general population to realize, number one, you're underfunded. Number two, your desire is so much more than money or any of these sorts of things that really don't make sense to even put onto you. They're about the desire to really create something that will build a better world. How do we convince the general population to understand that?
Yeah, you're so amazing, Alfonso. So I often say, and I mean this with every cell in my body, this job is the most humbling thing, because I meet families like you. Right? You are living your life, and then one day your child gets diagnosed with a brain tumor, and you go through the journey, and then you have to say goodbye to your child. And now you're running a podcast to try and help other families and to try and change it. It's the most humbling thing in the world. And that's why we're doing all of this as well, right? It's every child that we meet, like Inigo, we carry with us, and it's like they're sitting there saying we need to keep doing this together. So it's going to take a community of people to change the world, and it's going to happen. To very concrete things to answer your question, I think what you're doing right now, raising awareness, is really important, because a lot of people don't even understand that a child can get cancer, right? Let alone a brain cancer, and that children die. More children die of pediatric brain tumors than any other cancer, right? So it's a real thing. And I once had a family member tell me the number of children that die of brain tumors is like multiple plane crashing on the same day. Right? These are real children in real communities being absolutely devastated. So raising awareness is really important, as you are. You mentioned that pediatric brain tumor research is underfunded, and it always has been compared to adult cancers, because right? As we were talking before, because they're rare compared to adult tumors. But that doesn't mean we can't do anything about it. So people have helped in tremendous ways in the past. So advocacy, raising awareness, letting your elected politicians know that brain tumor research and pediatric cancer research as well is very important and important to you and to society. And then every community member will find a way that they can contribute. We have people walking or running marathons. I limp, I don't do marathons. But right, but if you look at the discoveries that have come from pediatric brain tumor research, it's almost 100% being funded by families and foundations and philanthropists. And then that allows us actually to do high-risk research. And once we do high-risk research and find exciting discoveries from that high-risk research, that then increases the chances of getting other funding from, for example, federal sources. So to answer your question, raising awareness, telling your story, letting people know that pediatric cancer research is important, and then advocating and just supporting research and programs just like you have been and many people have been.
Yeah. This idea that it's underfunded and it always has been underfunded. Could you help me understand, is that simply because in the grand scheme of things, the population of the needs are so small? Even though we're saying this is the number one killer in pediatric cancers, in the grand scheme of things, it's a very small population. So is that the issue? Is it that Big Pharma is looking at the situation and going, is this going to bring back enough dividends? Are large institutions, when they're doing the research, are they weighing out where the most value comes for them, as in how much of the population is it going to help? A larger group is better for them than a small group. Which of those mechanisms is the issue?
It's a good question, and it's probably a bit of both. So if you look at my lab or my research program, right, we get funding from federal sources at NCI, and then through multiple pediatric focused foundations and then private philanthropy and fundraising efforts. About 4% of the total NCI budget goes to pediatric cancer in general. Okay, so that 4% is incredibly precious, right? But we want that 4% to be higher than that.
Absolutely.
We want the federal budget for cancer research to be as high as it can be, and then for significant proportions, so that we're not, when we submit a grant to these federal agencies, which are absolutely invaluable, and the NCI is a pillar of cancer research for the US, right? But when we submit grants to get funding there, we're competing for all different cancer types, and less than 10% of all grants that get funded get sent in get funded to start with. Right? So that's one thing. So then the families have very much stepped in with foundations and philanthropy, and that has really, honestly, keeps a lot of the research going. You also talked about drug companies and pharma, and I will start by saying, especially for all of my colleagues listening from drug companies and pharma, these companies are full of really good people and good scientists who really want to change things.
Yeah.
But the structure of how companies are set up makes it really hard, right? So by law, right, publicly listed companies, you're answering to investors. So then it does become a money game, right? If you have a target where there are millions of people who might be able to use that drug in any 1 year, you're going to get a lot of money. But if you have a drug for a rare disease including a pediatric brain tumor, the market is a few hundred to a few thousands, right? That's the chance of making money back, particularly when it can take many hundreds of millions of dollars to develop a drug. It's hard to make that profit back. So, and then the other thing that we struggle with is and there have been efforts to try and change this, but we still have a way to go to incentivize companies when they're thinking about drug development to also develop the pediatric arm. And there's been, because of wonderful advocacy, again, changes in federal policy to incentivize companies. But if you have a company that has already got a drug that's approved for an adult indication, they don't necessarily have a lot of incentive to develop for children, and sometimes it can actually put their adult indication at risk. So there's just fundamental issues in this, systemic issues, just in how companies function and the need to make profit that makes it hard to have drug development for children.
Yeah.
It can be done, but it's hard. There was a company recently that did develop a drug that was approved for children, but it's hard and lots of things have to align. But I'm an optimist.
Okay.
I have to believe, right?
Absolutely.
With people working together, we can change things.
Absolutely. I love that. So Dr. Mimi, I just want to get a little granular. So Inigo's particular medulloblastoma, so there's 4 types. And so he ended up in a type, and I'm not going to go through them all because I don't actually remember all of them, but I remember there's type 1, there's type 2, type 3, type 4. He had type 4 in amongst all that. Regardless of the type, these novel trials that have happened have proven not to be efficacious with medulloblastomas. I don't know if you could help highlight why aren't we finding answers for medulloblastomas? Why are they so difficult to treat? What makes them so resistant to new treatments? I guess that's a whole bunch of stuff there. But yeah, my question is, why are they so successful at being cancer, essentially?
Yeah, and I think that's a really important question. So you are right. Actually, you're showing that when your child gets diagnosed with a brain tumor, you also become a doctor because you have a crash course in learning about things, right? So you are right. There are 4 types of medulloblastoma. There's a Wnt subtype, a sonic subtype, and then group 3 and group 4. And they are called group 3. So the first 2 are named after the main mutations that drive them, right? Group 3 and group 4 are named after numbers because we're still trying to work out what drives them. So that's one. But we're learning every day about the genes that make these different subtypes of tumors. I do think there will be drugs. There are efforts. There are major collaborative efforts across institutes that are trying to make models, right? So can we study the medulloblastomas in the lab by taking biopsies and make them grow? Can we make mouse models? And then can we take these and try to work out what other genes do each of these cancers need to grow? Because if we can find out what genes they need to grow, if we turn off those genes, then maybe we can make the tumors die. So there's specific efforts focused on medulloblastoma for that. There's a lot of excitement around, and as you described, Inigo was part of this, right? Can we work out ways to turn on the immune system? What we know is that every tissue in the body has the immune cells are a little bit different. So we're learning about the immune system for brain tumors and what the best targets are. But I do think that that's going to be an important part of this. So you're right. We don't have the answers yet that we need for everyone.
We were sitting in the hospital waiting for a surgical suite, and he said, "Dad, do you think they could put like little microscopic robots in there, like little spiders, and they could just like shoot it right into that tumor, and they could just eat it all up, after the resection. And then we end up going through the trials, and he was just so interested in what was coming next. And we as a family did our own research on all sorts of things, and we were, anytime a CAR T cell therapy article came through on Science, he would want to know about it, so we would read about it. We read another one, I think it was also CAR T cell therapy injected into the brain of a sea lion to heal them from a seizure situation that they were happening in this sea lion. And so he found that fascinating. And so he was so interested in, I would say it wasn't even about the healing process. He was interested in the mechanisms of what you guys were doing as researchers. That always fascinated him, and fascinated his curiosity in how you were trying to solve what was going wrong with him.
Yeah, I'm smiling because I can't remember if you're in the room, but I came in one day to Round, and he told me about the sea lion. He had the paper. He had an article, and he asked me about the sea lion.
Yes.
And then we talked about my lab. Actually, I remember, and we took So I 100% witnessed that.
Okay, good.
I loved it. I absolutely loved. We had a long discussion about the lab and what we do in the lab, and about growing cancer cells in the dish and immune cells, and
that's one of the things that I wish we could have done with him, was to have him go visit the lab, because he was so interested in the work that you all do, and I love that about him, and I'm sure that there's a lot of other kids that are also, when they're in this process. I don't know if we think about that as a general public either, how interested the kids are in the work that's happening to heal them. And
they very much are. So you asked earlier the things that people can do to raise awareness. If you are listening and you're interested in research, don't be shy in reaching out to your local hospital or researchers. We always love talking to people about research. So that's something else. And then you can go educate others about science as well.
Yeah, absolutely.
Yeah.
Science education is so important in today's day and age. Most people don't realize how little is still understood about pediatric brain tumors. What do you wish the public better understood about this particular field?
So I wish that more people would be talking about pediatric brain tumors and that they occur in children, and treat it as the emergency that I see it is. We should not be losing children to cancer. We should not be losing children. I want every child to have the possibility of going and doing all the stuff that they are destined to do, right, in the future. So that's what I wish people. I don't necessarily want people to know what is the mutation that causes tumors or whatever.
Sure.
But I want people to know that children get brain tumors, and that they need an army of people around them to support them through the treatment. But we don't know whose child is going to get a brain tumor today or tomorrow. There are people who are going to need help that don't even know that they need help yet. Okay? So the community, people, when we come together, we can change things. And so being there for the families who are going through this and are going to continue to go through this, and helping them through this and trying to change things. That's what I want people to know.
That's amazing. So for parents that have a child with a brain tumor right now, what is it that they can do? So as a researcher, when you walk into that room and you have to give them some hard answers, and they've run out of the traditional pathways, what is it that they can do to help you, both for their child trying something novel and for your research?
Yeah, so let's talk about their own child going through that journey first. Never be shy to ask questions, right? No one is ever going to say, why did you ask me that question? Know that we'll, in the pediatric brain tumor field, we all work together and not against each other. So never be shy to ask about what are trials and what trials are going on around the country, even if it's not in the center that you are. Never be shy to ask for a second opinion. They're my sort of things there. And then always have hope. Okay. Knowing that every day we're continuing to work in the lab, and I wish we have answers for everyone, but every day we are getting closer to having more answers. So have that hope.
Yeah. That's what I love that. So in the middle of the fight, don't give up the hope. Never give up the hope. Yeah, you were so good with us with that. We, especially as we got towards the end, and I came across an article, and I may have talked to you about it at the time, but the article in particular discussed the concept that we don't know how to die in this world. We don't know how to walk through that process. And that was an article about adults. For children, you should never have to learn how to die, right?
Yeah.
And you were so generous with being so careful with us and what we were going through. I just appreciate that about you so much, and the teams at Boston Children's Hospital and at Dana-Farber and all these places that you guys do carry heart with you into that room to deal with the people that we are and the people that our children are. And you never see them as a research implement, but you see them as a little life. And I think that that's so special,
Because that's what they are. You all are, right? This is who we all are, right? We're people, we're human. And that I was, every time I hear what's in Matilda, I think of Inigo. Every time I have a Tim Tam, I think of Inigo. And then Caramello Koalas, I'll never forget. You might remember he was sitting out of his bed drinking hot chocolate and these Australian chocolates that my friend had brought, caramel koalas, and he was like, delicious. And he was so high, right? So that was actually something Inigo taught me, and you taught me, and Lindy taught me, is finding joy in every moment, despite what you're going through, right? Every day I'd walk in and there was a happy Inigo sitting there with something he was looking forward to, something he was enjoying, and finding joy.
Absolutely. We want parents to understand that your child may have cancer, but it doesn't define them.
Right.
And yeah, it's, yeah.
And I think you lived that.
Mm-hmm. Yeah, we did. I know I've kept you too long, but I do have 2 more questions for you, if that's okay. So,
absolutely.
When you look ahead, what gives you hope for the future of pediatric brain tumor research?
I keep using the word community a lot, but that is actually what gives me a lot of hope, right? Is that there are hundreds of people all around the world working together, even though we might be physically. And the technologies are evolving, our discoveries are exponentially going up. And I think we will move from a day from where it's chemotherapy and radiation to maybe a little bit of chemotherapy and radiation, but drugs that then target the mutations, drugs that target the immune system, drugs that get multiple ways to attack that cancer cell so it can't evolve and become resistant. So I do believe, just looking at how quickly we are learning things, also acknowledging that we're not doing it quickly enough that we're able to have an answer for every child. But I do think we are going to get there. The other thing that gives me a lot of hope is, and I've told this story to many people, so I apologize if I've told this to you already. When I was in Australia, I went to, there's this little town called Daylesford, which is, I don't even know what the equivalent would be here. It's sort of like a little quaint little town where you go to for the weekend away in antique stores. And I walked into this antique bookstore, and there was a book of pediatrics, handbook of pediatrics, that was printed in 1957, which is the year my clinical mentor in Australia was born. So I honestly bought the book so I could tease him and say, hey, look, here's an antique bookstore that was published the year that you were born. But then I was like, hang on, I've got this book called Pediatric. So I looked up leukemia, right? So I looked up brain tumors first, and there was nothing. There was there was nothing about pediatric brain tumors. So I looked up leukemia, and it said leukemia is the most common cancer that occurs in children, which it is, right? Brain tumors are the most solid leukemias. And then it said the average life expectancy is 6 weeks. This was in the early 2000s. And at that point, the cure rate for the most common pediatric leukemia was 90%. So in 50 years, we went from average life expectancy of 6 weeks to 90% of children being cured. We've done this already. Okay. And actually, a lot of that came out of Dana-Farber. The institute is named after Dr. Sidney Farber. He was one of the first people to make children with leukemia go into remission by using chemotherapy. So it can be done. Mm-hmm. We just didn't have the research tools and the technologies to do it for pediatric brain tumors, but we have them now. So I see hope that we are going to get there for kids with brain tumors.
Keep going. Keep going. Okay, one final. That was beautiful, and I love that, but I do want to leave with one final question, which is, what is the biggest barrier to breaking through that wall that you're talking about? So if we did that with leukemia, and by the way, I've read the story about that, and I just find it so incredible, and that's why I just want to be a cheerleader for you guys, because I know you're going to do it eventually. But what is the biggest barrier to breaking through that?
Yeah, that's a good question. I think we're getting there with technology. We need to sustain awareness, and we need to sustain the funding and resources so that the research doesn't slow down. We need to keep expanding the research and adding momentum. And so that would be my thing. Biggest barrier is knowing that it's underfunded to start with, making sure that we can, as a community, keep the funding going to support the families going through it and to support the research to find those answers.
Absolutely. Oh, thank you so much for that, Dr. Mimi. So for anybody listening out there, please be an advocate for this space. Please be an advocate for the cancer institutes in your particular area where you might be. I know here in Boston, we're looking at Dana-Farber and so many other places that are so focused on doing this research. Children's Hospital, Harvard, the Broad Institute, Dr. Mimi and her team, and so many others in that area that are working so hard to find the cures for these underfunded and rare. Oh, I do want to make a statement on that. Inigo disliked very much that his cancer was called rare.
Yeah.
And the reason why, he said, is that I have it.
Yeah.
I have it.
Inigo is so insightful. He's right. That's the statement we say, right? You can say it's rare, but if you're the one that has it, right? And so, yes, it's 100%, and that's why we need to do this. Yeah. Right? It's no consolation to someone to hear something's rare when you're living it. So, yeah, I'm with you there, 100%.
Yeah, he would say, stop calling it rare. And so, yeah, absolutely. Be an advocate in your space, wherever you might be. Dr. Mimi, thank you so much for your time and the heart that you put into this with your team and everyone around you. What special people you are. We need to multiply you by the millions and try, just...
My family might be a little scared.
Yeah, but it's all from the heart. We just love you, and Inigo loved you and loved everyone there. And so I will close with this. Pediatric brain tumor research is more than science. It's a commitment to children, families, and the future. Progress depends on collaboration, understanding, and the shared belief that every child deserves a chance. So Dr. Mimi, we love you. Thank you so much for the work that you do, and thank you so much for coming on with us.
It's my pleasure. We love you back, all of you. So thank you for having me.